Hello class, so welcome to the third and last part of our discussion on the disorders of the thyroid gland. So in this part of our discussion, we're going to discuss hyperthyroidism and thyrotoxicosis. So thyrotoxicosis is a state of thyroid hormone excess. So it's any or your hyperthyroidism is um, sort of under thyrotoxicosis. So in hyperthyroidism, is a result of excessive thyroid function. So you can have thyrotoxicosis without hyperthyroidism, or you can have thyrotoxicosis because of hyperthyroidism. So they're not interchangeable with one another. So in hyperthyroidism, we have king thyroid, no, and he's producing too much and the body is already complaining, and the TSH is telling it to cut back a little, but he's not listening and he wants to produce more thyroid hormone, and this can result in thyrotoxicosis. So what are the causes of hyperthyroidism? We can actually classify causes of hyperthyroidism into four kinds. No, you have excessive TSH receptor stimulation. So remember, when you activate the TSH receptor, it can activate almost all the steps of thyroid hormone synthesis and release. No, so the classic condition that is where you have excessive TSH receptor stimulation will be your Graves' disease, where you have TSH receptor antibody that stimulate your TSH receptor. You also have pregnancy-associated transient hyperthyroidism. So in pregnancy, especially in early pregnancy, you have markedly elevated beta HCG, and remember your beta HCG has structural similarities with your TSH, so it can actually bind to your TSH receptor and therefore stimulate it. You can also have trophoblastic disease, also mediated by your beta HCG. You can have familial gestational hyperthyroidism and TSH producing pituitary adenoma. And these are very rare conditions. I think the only thing that you have to just remember are the first three. So you also have your autonomous thyroid hormone secretion, meaning it's within the thyroid that's producing too much thyroid hormone secretion. So it can be from a multinodular toxic goiter, multiple nodules caused by somatic mutation, causing multi, uh, multiplication of your cell, causing nodules, and this can autonomously secrete, no, more thyroid hormone, not in response to your TSH. And similarly, you have your solitary toxic thyroid adenoma. That's just one thyroid nodule. Usually, it's a baked thyroid nodule that's with symptoms of hyperthyroidism. This one, congenital activating TSH receptor mutation, that's very rare, nice to know. And then the third class of disorders that cause hyperthyroidism are destruction of follicles with release of hormones. So this is it's actually not hyperthyroidism per se, more of thyrotoxicosis. So these are your thyroiditis condition. You have your subacute degradations thyroiditis, usually after a viral infection. You can have venous thyroiditis or even postpartum thyroiditis or acute thyroiditis from a bacterial infection, a drug thyroiditis from amiodarone. So take note that amiodarone is not exclusive to hypothyroidism. Sometimes the the effect of amiodarone can be idiosyncratic and it can go both ways. It can either go hypothyroidism or hyperthyroidism depending on the response of the patient. Others would be extrathyroidal sources of thyroid hormone. So this is more thyrotoxicosis, not really hyperthyroidism. So this could be a iatrogenic overreplacement with thyroid hormone. So for example, you'll have a patient with um, hypothyroidism when you're already replacing with levothyroxine and the dose is too high, then you can have um, thyrotoxicosis from excessive thyroid hormone intake. Excessive self-administered thyroid medication, that could be your thyrotoxicosis practitia, we talked about that earlier. Functional thyroid cancer metastasis, not very common. Struma ovary, it's an ovarian tumor that causes excessive thyroid hormone secretion. So that's an extra thyroidal source of your thyroid hormone. So overall, these are your differential diagnosis in any patient presenting with symptoms of thyrotoxicosis or with biochemical findings of um, hyperthyroidism. What are the causes of thyrotoxicosis? It could be from primary hyperthyroidism, it could be from here. So we talked about that. So here are your different conditions that can cause primary hyperthyroidism. Thyrotoxicosis without hyperthyroidism, as I mentioned earlier, usually these are your thyroiditis conditions. Secondary hyperthyroidism, everything from the pituitary or central, you have your TSH producing pituitary adenoma, and even your chorionic gonadotropin secreting tumors, and of course your gestational thyrotoxicosis. So how do these patients manifest? No, it's the opposite of hypothyroidism. Everything is fast. No, the metabolism is fast. Patients would manifest with hypercatabolism. Usually, these patients will manifest with hyperactivity, irritability, dysphoria. Sometimes they present with mania. Sometimes this patient will have difficulty falling asleep because their brain is always awake and always alive, very easily irritable with the smallest things. They will have heat intolerance and sweating because of increased thermogenesis, no? Because the body is trying to dissipate the excess heat. No? This patient would have a warm, moist skin, no? So, and excessive sweating in order to dissipate the excessive heat from the excessive thermogenesis. These patients will have also palpitations because of the alpha adrenergic activation in your heart, fatigue and weakness, weight loss, even with increased appetite because of the hypercatabolism. Remember that in hyperthyroidism, you have increased carbohydrate metabolism, increased fat metabolism, increased protein synthesis and degradation. No? So you also have polyuria, thirst, oligomenorrhea, or anuria, loss of libido. So the gynecologic symptoms will be very similar also with hypothyroidism. Physical manifestation can have tachycardia, sometimes atrial fibrillation in the elderly, or especially in patients with thyrotoxic heart disease, they can have atrial fibrillation. Hypertension, as I mentioned earlier, you can have, usually it's a systolic of hypertension. So if you have a systolic hypertension, you can have an increased pulse pressure. No? Remember your pulse pressure, the difference between your systolic and your diastolic blood pressure. Because of you could have also have fine tremors, hyperkinesis. No, some patients would have. You can see that when they pray Amanamin or Our Father during Mass, they would have tremors. Can have goiter, of course, warm, moist skin, hair loss, muscle weakness, proximal myopathy. Some patients with hypokalemic periodic paralysis, no, very low potassium, unable to both legs. No? That can also be a manifestation of thyrotoxicosis. Lead retraction or lead lag, gynecomastia, and mental status and mood changes, either mania or depression. So how do we evaluate these patients, no? With presenting to us with symptoms of thyrotoxicosis? Again, if it's very profound, if it's very overt, no, we can measure both TSH and T4 at the same time. Unbound T4 or free T4. If the TSH is low and the free T4 is high, then you can say this is primary thyrotoxicosis or primary hyperthyroidism. Um, if there are features of Graves' disease, let's say there's exophthalmos, there's a diffuse goiter, then you can say yes, it's Graves' disease. So usually, if it's a diffuse goiter, no, if it's a diffuse goiter with primary hyperthyroidism on your thyroid function test, it's usually Graves' disease until proven otherwise. No? So if there are no features of Graves, you probably, if it's multinodular, there are nodules or a toxic adenoma, then it could be toxic nodular hyperthyroidism. If not, then you check the thyroid scan. If there is no uptake, there is no increase in radionuclide uptake in thyroid scan. Remember your thyroid scan before? It could be from other causes. Probably if the patient is female, it could be a chorionic gonadotropin secreting tumor, or if there is a low radionuclide uptake, then most likely your thyroid gland is destroyed. You have destructive thyroiditis, iodine excess or excess thyroid hormone. The excess thyroid hormone is blocking the sodium iodide symporter. Therefore, um, the iodine 131 or the technetium radionuclide cannot be taken up by the thyroid. So it would appear to have low radionuclide uptake in the thyroid scan. If it's not, if it's, yeah. So if the patient has a TSH that is low, but the FT4 is normal, then it's the time you measure your T3 to look out for your T3 thyrotoxicosis. If it's T3 thyrotoxicosis, then you follow this algorithm. If the T3 is normal, T4 is normal, TSH is low, then your interpretation is subclinical hyperthyroidism. You just follow them in 6 to 12 weeks. You just repeat the TSH, FT4, and FT3. If the TSH is normal or increase unbound FT4 or increase FT4, then you can think about something central. Let's say you have a normal TSH, an elevated FT4, or an elevated FT4 with an inappropriately normal TSH, or an inappropriately elevated TSH in the sense of an elevated FT4. And then you have a goiter, you have thyrotoxicosis. It could be something central, TSH secreting pituitary adenoma, or the rarer conditions, thyroid hormone resistance syndrome. If the TSH and unbound T4 is normal, then there's no further test. Probably the symptoms of thyrotoxicosis is from something else, not thyroid. So let's go first to the most common cause of hyperthyroidism, which is Graves' disease. It's more common in females and in areas with high iodine intake. But of course, it can also happen in males, so it's not exclusive to females. So smoking is a major risk factor. It's a minor risk factor for Graves, but if you have a patient with Graves' disease and the patient is a smoker, it's a major risk for the development of ophthalmopathy. And it also makes the Graves' disease harder to treat, if the patient is smoking. So usually that's one of the things that I advise my patients, stop smoking if you have Graves' disease. There's also 3 times increase in occurrence in the postpartum period. If you have a Graves' and then you get pregnant, the pregnancy will have sort of an would help the patient develop immune tolerance, meaning it will try to suppress the autoimmune hyper response of the body. And most patients, but of course not all, most patients with Graves' disease would have sort of uh, abating of their Graves' disease. Sometimes patients who were previously on medication, during pregnancy, we are able to take off their medication because of the immune that's caused about by the pregnancy. And once the mommy has delivered, usually the Graves' disease will come back, and will come back. Or if the patient has had no Graves' disease, the increase in occurrence of Graves' is usually higher in the postpartum period. It also may occur during the immune reconstitution phase after your treatment with BRTs. So how does this happen? In the thyroid gland, you have TSH receptor antibodies that are thyroid stimulating, also called your thyroid stimulating antibodies from your B cells, and then this will cause activation of your TSH receptor. and the TSH receptor will become overactive, and the overactive TSH receptor will now result in the activation of your thyroid hormone synthesis, your hypertrophy and hyperplasia, resulting in a diffuse goiter. So how about in the eyes? No, in the eyes, you have Graves' ophthalmopathy. So how does this happen? So your same thyroid stimulating antibodies from your B cell will result in activation of your TSH receptor, no, in your TSH receptor in your fibroblast, no, in your beneath the eye, no, in the muscle beneath at the back of your eye, and the activation of your TSH receptor will result in increase in the uptake of your hyaluronan and glycans, inflammatory molecules, and this will result in differentiation into myofibroblasts and increase orbital fat expansion and increase orbital tissue volume expansion. Therefore, if the muscles, the myofibroblasts behind your eye will have increase in volume, then your eyeballs will now protrude like that, which will result in ptosis. Sometimes, in severe cases, you can also have optic nerve compression. So this is a classic of a patient with Graves' disease, no? Diffuse goiter with eye symptoms. You have your exophthalmos, and when you auscultate the thyroid gland, you will have increased vascularity because of the hyperdynamic circulation within the thyroid gland. This manifests as a thrill or a bruit when you auscultate the thyroid gland. So again, in a patient with diffuse goiter and hyperthyroidism, with or without eye signs, no, that's usually Graves' disease. So not all patients with Graves will have exophthalmos, not all. Okay, so your disease could have thyroid-associated ophthalmopathy or thyroid-related eye disease. Note the thyroid tear, asymmetry, proptosis, periorbital edema. So this is your Graves' orbitopathy, and after treatment with orbital decompression surgery, no, these patients would have normal-looking eyeballs. So what's the danger with having exophthalmos? So these patients would sometimes have difficulty closing their eyes, no? And this can cause excoriation, bacterial infection, very hard to treat. No? Aside from, of course, as I mentioned earlier, optic nerve compression. How about in the skin? This is a rarer manifestation of your Graves' disease. This is called the thyroid dermopathy. No? It occurs in less than 5% of patients with Graves' disease. This is a very severe kind already. Usually, they just look like this. No? This is a plaque form of your tibial dermopathy. Sometimes it's just thickening of the skin. But in patients with chronic thyroid dermopathy, the chronic pretibial edema, they would look like this. Very, 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 very thick skin. So most patients with thyroid dermopathy, or if not all patients with thyroid dermopathy, also have Graves' ophthalmopathy. And this is the rarest of the other manifestation of Graves'. This is your thyroid acropathy. So this is because of the hypermetabolic state, it leads to eggshell bone destruction, and secondary to enhanced osteoclast activity. So even the osteoclast would have increased activity because everything is fast, So again, acropathy should not be confused with clubbing. Looks like clubbing, but in a patient with Graves' disease, this is not clubbing. No, it's not very common. I have not seen this in my patient, only dermopathy, because it only occurs in less than 1% of patients with Graves, and it is also strongly associated with thyroid dermopathy. And usually, patients with thyroid dermopathy, thyroid acropathy will also have Graves' ophthalmopathy. But again, not all patients with Graves will have ophthalmopathy. So how do we evaluate these patients? Of course, the picture of the thyroid function test will be a suppressed TSH and an elevated FT4, signaling a primary hypothyroidism. And the next test, the next most important test, would be to do a thyroid scan to confirm the presence of an increased uptake in the thyroid gland. Because some patients, especially in the hyperthyroid case of Hashimoto's thyroiditis, they can have a suppressed TSH and an elevated T4 and a diffuse goiter. But when you do the thyroid scan, there's no uptake. If there's no uptake, that's thyroiditis, okay? So the treatment will be markedly different. So that's why it's very important to do a thyroid scan to confirm if this is really Graves' disease, especially if you're contemplating doing definitive therapy. No? So for example, if you have a patient with thyroiditis, then it's not warranted to do a thyroid scan. It's not warranted to do RAI. It's not warranted to do a thyroidectomy, except, of course, if the patient is suspected to have some form of malignancy. But if not, if it's just thyroiditis, we just give symptomatic relief, usually with beta blockers, because eventually these patients will go into hypothyroidism. Next would be thyroid ultrasound, no, to check for coexistence of nodules, and if the diagnosis is still unclear, despite your thyroid scan, your thyroid ultrasound, and also, before I forget, in thyroid ultrasound, these patients would have increased color Doppler flow. So if you don't have thyroid scan in your area of practice, and your thyroid ultrasound shows increased color Doppler flow, meaning there's increased circulation in the thyroid gland, that can also be a way for you to diagnose Graves' disease. Not TSH receptor antibodies if the diagnosis is still unclear. But if it's already clear cut, no need to request for your TRAB because this is a very expensive test. If you have a patient with Graves that is already in their third trimester of pregnancy, you can use TRAB to predict the possibility of neonatal thyrotoxicosis. So how do we treat? So usually when I have patients with Graves' disease, I let them choose what kind of treatment they want to receive. So we can choose from either giving anti-thyroid drugs, radioactive iodine treatment, or surgery. So if you give anti-thyroid drugs, usually we give 1 to 3 pills per day, usually in the form of methimazole or PPU for at least 18 months. No, at least 18 months. Usually at the end of 18 months, 9 out of 10 will have no symptoms anymore. No, however, if we stop the ATD, only 4 out of them will actually go into remission. And the rest of the patients who discontinue anti-thyroid therapy and are not cured go on to either RAI or surgery. So this is what I tell my patients. If you choose this option, only 4 out of 10 will be cured at 18 months. And they have to be very diligent when they take their medications. No? Because if you discontinue, you can be at risk for exacerbation or thyroid storm at worst. No? If the patient proceeds to choose RAI in RAI, you only give the radioactive iodine capsule once. No? And usually at the end of 18 months, 10 out of them will be cured. Usually 6 months, most of them will be already cured at that time. And the thyroid is permanently inactive. And when the thyroid is permanently inactive, that Graves' disease is cured. But you will have hypothyroidism. Similarly, in surgery, you remove the thyroid gland. Usually, this is indicated in patients with very, very large goiters, where ATD remission will be the risk of ATD remission is very low, and it will be also hard for the radioactive iodine to control that very large goiter. So we usually go for surgery in those kinds of patients. And immediately after surgery, the Graves' disease is cured. But, of course, you will also have hypothyroidism after. But between hyper and hypothyroidism, I'd rather have hypothyroidism. Remember that patient earlier who had no treatment for 30 years? She's still alive without thyroid hormone replacement therapy. But in patients with Graves' disease, who are left untreated, they have a lot of complications, and the risk of dying is higher. So if the ATD is effective, most of them will not need thyroid hormone replacement therapy. In RAI, most likely majority of them would need thyroid hormone replacement after. And that's the same also for surgery. And the average of 3 months to achieve normal thyroid levels will be 3 months, no? After 3 months of replacement. So usually after you've replaced the patient with levothyroxine, at 3 months their TSH will start normalizing already, and the intake will likely be lifelong. Possible complications with anti-thyroid drugs, some patients will have side effects like rash, itchy skin. In rare cases, we can have agranulocytosis. And 1 out of 4 people will drop out, because of the side effects. And the eye disease will remain unchanged. In REI, you have to isolate for a couple of, usually 7 days, and you cannot get pregnant for at least 6 months. But after 6 months, you can go ahead and get pregnant, no? In patients with moderate to severe eye disease, RAI is not recommended because RAI can worsen eye disease. In surgery, no, of course, you will have to be admitted in the hospital. You can have a scar in the neck. Some patients would have temporary hoarseness, especially if the superior laryngeal nerve is disturbed. Some 1 out of 100 people will have permanent hoarseness. So the skill of the surgeon is very important in this aspect. No? Again, the skill of the surgeon is very important in this aspect. Some patients, 1 out of 100 people, will need calcium pills for a lifetime if the patient develops iatrogenic removal of your parathyroid glands. And that will be very devastating because this patient will have severe hypocalcemia. So again, it's very important to have a very skilled surgeon to do your thyroidectomy, and it will not have any effect on your eye disease. So how do we, if the patient chooses anti-thyroid drugs, or you're waiting for definitive treatment, like you're preparing for RAI or you're preparing for surgery, you can give medical treatment, no, in the meantime, in the form of either PTU or methimazole. But usually we give methimazole because it's usually just once daily dosing, no? Unlike with PTU, you have 2 to 3 times a day dosing, no? Usually, the only indication right now for PTU would be first trimester pregnancy and thyroid storm. So usually in pregnancy, when the patient enters the second trimester, we usually shift them from PTU to methimazole until the patient delivers, and then even in the postpartum period. Side effects, the dreaded ones would be your agranulocytosis, although this is very rare. Beta blocker, usually we give this for the adrenergic effects of your hyperthyroidism. Propranolol is usually the most popular one for hyperthyroidism because at very high doses, no? Remember, at very high doses, it may block the conversion of your T4 to T3. Remember the peripheral conversion of your T4 to T3? Your propranolol can block that, no, at very high doses. So in patients with thyroid storm, no, we give very high doses of propranolol in order to block this as well. No? You can also give metoprolol. Metoprolol is a selective beta blocker. Usually, I give this for asthmatic patients who cannot be given propranolol. Usually, propranolol can trigger asthma attacks in patients with bronchial asthma. You can also give atenolol. The advantage of which is once daily dosing. Other causes of thyrotoxicosis, it could be destructive thyrotoxicosis. In these patients, during the initial destruction of your thyroid gland, you can have a short thyrotoxic phase because of the release of the thyroid hormones. Then they will go into a euthyroid phase. And once all the thyroid hormones have been released and consumed, and the thyroid gland is destroyed, it cannot produce any more thyroid hormones, patients go into the hypothyroid phase. Thyrotoxicosis factitia, you can have exogenous intake of thyroid hormone. Patients who would like to lose some weight, no, and have some medical background, that's the typical clinical scenario. Except they sometimes take levothyroxine in order to lose weight. No? But when you check the thyroglobulin, they would usually have low levels. Patients with iodine excess, ectopic thyroid tissue, TSH producing pituitary adenoma, toxic multinodular goiter, hyperfunctioning solitary toxic nodule. So we already talked about that earlier. Okay, so that's my last slide. So I will leave it up to you guys to read about thyroid storm and subacute thyroiditis and its treatment. You read your Harrison's, no? And other references. And I'll see you on our next session. Bye-bye. I'm sorry, I forgot the summary. So to summarize the whole three parts of this session, no? These are the things that you really have to remember. No? That the most common cause of an overactive thyroid are Graves' disease and a toxic multinodular goiter or even a toxic adenoma. But usually it's Graves' disease. Graves' disease is caused by autoantibodies to the TSH receptor acting as TSH receptor agonist, no? Agonist, not antagonist, resulting in thyrotoxicosis. Treatment, anti-thyroid drugs, RAI, or thyroidectomy, and we monitor with FT4. In hypothyroidism, you can have endemic goiter and cretinism caused by iodine deficiency. But in other instances, in iodine-sufficient areas, it could be autoimmunity. No? Usually, Hashimoto's is the most common cause of autoimmune thyroiditis. In these cases, the next most common will be iatrogenic hypothyroidism after an RAI or after a thyroidectomy. And hypothyroidism is treated with hormone replacement with levothyroxine, and we monitor using TSH. So that's it. That's my last slide. So I hope you learned something from this session, and I'll see you on our next session.